from Alchem Lab. I'm a qualified doctor with a post-graduation in MD Pharmacology. On behalf of Alchem Lab, it is my great pleasure to welcome you on this international speaker program. As you know, epilepsy is one of the most common serious neurological disorder affecting more than 70 million people worldwide. And despite the addition of nearly 20 new anti-epileptic drugs in the last 2 to 3 decades, still more than 30% of the patient fails to achieve the prolonged seizure freedom. Further, many patients suffer from the adverse effect of AEDs, which is responsible for poor adherence as well as discontinuation of ASD. Therefore, the need to discover the new AED with the improved efficacy and better tolerability profile is always been there. So considering the same, we as a Alchem also launched some of the new molecule, that is a brivaracetam as well as the parampenal, which is also approved by the important regulatory bodies. And we want to disseminate this information to all you people, all the Indian audiences. So for this, we have an eminent international speaker, Dr. Felix Rosenow, who is a professor and director of the Epilepsy Center, Frankfurt. Sir will talk on the disease unmet need, novel treatment option, and will try to address all your queries, whatever you are having. And before doing the same, I mean, the introduction part of speaker as well as the panelists will be done by Dr. Sanjeev Thomas. So who is a chairperson and who is going to moderate our event also. So I'm just introducing Dr. Thomas, and post that Dr. Thomas will introduce all the speaker as well as the panelists. So I'll just briefly introduce sir. So Dr. Sanjeev Thomas, sir is a DM neurologist with a fellow in ANA as well as the AN as well as AMS and the IN. Sir currently is a professor of neurology and director at the ICANS Trivandrum and Shoranpur. Sir is a Fulbright professor. Sir was a Fulbright professor at OSU, Oklahoma State University, Columbus, 2011. Member for the Asia Oceania Epilepsy Commission 2021 and 25. Ambassador for the Epilepsy, International League Against Epilepsy and the International Bureau of Epilepsy since 2019. Sir is an ILA Commission on a Medical Therapy core member from 2017. ILA Task Force member for the Women with Epilepsy since 2017. And also, sir is also in the ILA Task Force for the treatment guideline part. Sir is active member in an uncommitted treatment guideline. Especially the focus area was women with the epilepsy. Sir was a past president of the Indian Epilepsy Society from 2018 to 2020. Sir was the president for the Indian Academy of Neurology 2017-18. And sir was a editor also for the Annals of Indian Academy of Neurology 2006 to 11. Sir has published more than 120 papers. And with this, I think I will hand over this session to Dr. Thomas. Sir, over to you, sir.
Thank you, Nitin. Good evening, warm good evening to all of you from Trivandrum. And this evening we have a very rich academic program, and my first responsibility is to introduce the main speaker for the evening, Professor Felix Rosenow. Felix Rosenow is the professor and director of the Epilepsy Center at Frankfurt in Germany. He's a faculty of the Wolfgang University in Frankfurt. He has academic qualifications based on his extensive research work on electrocorticography, and his doctorate is again in neurology. He has been awarded several fellowships and scholarships during his career. He was the president of the German Society for Clinical Neurophysiology and Functional Imaging. He is a winner of a competition on innovation in medical technology, and he has a large number of publications and his specializations in the epilepsy. Today, he will be speaking to us on the newer anti-epileptic drugs and its role in the management of epilepsy. As you know, the as it was just now mentioned, the epilepsy treatment had been undergoing a transition. In spite of several newer molecules being added, still around 30% remain poorly controlled of seizures. We have come to an age when we are talking about differentiating anti-seizure medicines from anti-epileptic medications. And in future, probably we will have two classes of medicines which may be helpful for people with epilepsy. So in this program, after the main talk, there will be a panel discussion, and that will be guided by a panelist who are basically from different parts of the country, Dr. Manoj Gulani, Dr. Shivakumar, and I have to get the, 1 second. I have a problem in my seeing my screen. I think the problems which you had faced, I am now facing. Let me go to my mobile then. I think the problems which you had faced, I am now facing. Yeah. I will talk about
So
Dr. Manoj Gulani is from Nashik. He is a senior consultant in Nashik in Maharashtra, and he has done his general medicine followed by neurology. And am I echoing? Is it me who is echoing?
No, sir. Please continue.
Okay. And we have Dr. Meenakshi Sundaram from Madurai, and is a younger Meenakshi Sundaram from Madurai, different from the Meenakshi Sundaram of Chennai. And we have Dr. Shivakumar from Bangalore, who is a fellowship in epilepsy and is working on epilepsy surgery. And we also have Dr. Datta from Kolkata, another important neurologist who is contributing a lot to the epilepsy care in that part of the country. So these panelists will be also contributing on their experience in the management of epilepsy with the newer anti-epileptic drugs. What are the promises, what are the challenges, and how they foresee the future of newer anti-epileptic drugs. With this introduction, I would request Professor Felix Rosenow to give his talk, and this will be followed by the panel discussion. Thank you.
Yes, hello, ladies and gentlemen, dear colleagues. Thanks for having me. I will try to share my presentation. Let's see whether you can see that. Can you see that okay?
Yes, we can see it.
Good.
You'll have to put it in the slideshow, I believe.
Yeah. Is it now? It should be in the slideshow.
Yeah,
huh?
that's right.
So this is the task of me today at this Be Sure Summit 2021 to speak a little bit about managing epilepsy with newer anti-epileptic drugs. And I will put a strong focus on brivaracetam and talk a little bit on perampanel because that's been around for a little bit longer. If you have problems understanding me due to my German accent, let me know. I can always try to speak a little bit slower. So this is my conflict of interest slide. You see I have received personal fees from a couple of companies, including UCB Pharma, which is maybe most relevant here. I have some grant supports, which may also be of relevance. And most importantly, I'm part of this Center for Personalized Translational Epilepsy Research, which is currently funded by the federal state of Hesse in Germany. Just to show you where I'm sitting right now, this is Frankfurt seen from space. See the Frankfurt airport, which some of you may have gone through at one time or the other. This is most importantly our soccer stadium. We don't play cricket here, we play mainly soccer. And this quite near is the epilepsy center, so sometimes I can even hear the games. Furthermore, this used to be a racing place for horses, but now the German soccer league is building their main center here in their training ground. So the German national team will be playing here. So now you know where I'm sitting. I'm sitting in this building here. And let's get started. I will go a little bit into how to choose an anti-seizure drug today. Then I will go on a couple of things in brivaracetam, which you can see here. We will go through this in a minute and talk a little bit about perampanel regarding its approval in generalized genetic epilepsy. So if you start a new medication, or if you choose any drug actually, or any anti-seizure drug for a patient, you will always have to recognize that immediate seizure control is quite important to prevent injury and deterioration of the patient's socioeconomic situation. At least in Germany, if you have a seizure, you cannot drive any longer, and that obviously puts many jobs at risk. So you want that control back as soon as possible. The other thing is, even though you want to have control rapidly, you also should consider that the patient is likely taking this drug for several years. So you don't want too many interactions, you don't want any long-term side effects that are unwanted. Many patients with epilepsy will either have already or will develop over time comorbidities during this long time during which they will take the drug. And psychobehavioral comorbidities such as depression, suicidal ideation, anxiety disorders, or psychosis are quite frequent in this population, and they can sometimes be worsened by anti-seizure drugs. Therefore, the choice of the first initial monotherapy is quite relevant to the patient, but also later on during the course of the disease, it's important which kind of drugs you add on to this treatment. Sometimes epilepsy type is unknown. Certainly initially that's often the case, and then you want to have something that's broad range, and that would be preferable if the drug was effective against different kinds of epilepsy, including generalized idiopathic epilepsy. So what is the knowledge we have about initial monotherapy? We have 4 trials which all compared the newer compounds to carbamazepine XR, so extended release. And here you have the number of patients who stayed seizure-free for 6 months under the last dose reached. And you see this is the initial comparison with levetiracetam. It's nearly identical regarding efficacy. Sonizumab was also non-inferior, so it was approved for monotherapy as well. Eslicarbazepine, also approved for monotherapy. And then you see lacosamide compared here. So you can see, unluckily, that gap of 30% of patients that still don't have the seizures controlled still exists with the newer drugs so far. We also, in my team, we compared initial monotherapy of lamotrigine to levetiracetam, and there was also no difference, no significant difference between the two of those, even though levetiracetam looked a little bit better initially. So how do we choose seizures? We not only look for efficacy, but we also look for comorbidity. And you see here some patient characteristics or comorbidity: depression, obesity, pregnancy or the wish to become pregnant, tremor, co-medication. And you see example drugs which can have positive effects or negative effects. And that's a little bit how we choose. If the patient has a depression or tendency to be depressed or depression in the history, you could use valproic acid or lamotrigine in order to stabilize his mood a little bit. You would probably not want to use levetiracetam and topiramate. If obesity is the main problem, then topiramate might be a good choice, but valproic acid and pregabalin might not be such a good choice. If the patient wants to be pregnant or is pregnant, then lamotrigine or levetiracetam are quite good choices. We have good data on that by now. Valproate is a bad choice. Tremor, if it's an essential tremor, you can treat it actually with primidone, which is actually a drug which we don't use very often in Germany otherwise anymore. And on the other hand, valproic acid and lamotrigine can make it worse, can make tremor worse, can even cause a kind of Parkinsonian syndrome. Then if you have a lot of co-medications, you want something that's inert and is not doing interactions. You don't want enzyme inducers or inhibitors. As has been mentioned before by Dr. Thomas, there's a lot of drugs, and many of those are relatively recent. And I show you here in red the ones that are still used a lot in Germany and are approved for use. And then in black, you see those that are used only in special situations or that are used not so frequently anymore because they're either orphan drugs or they have had problems in the past. So they are not used extensively. You see the most recent ones on this slide are perampanel and brivaracetam. We will not go into these two drugs, which have only orphan drug approval in Germany. And I will not mention cenobamide today, which is a new drug approved a couple of weeks ago here. So, we go into brivaracetam, the preclinical and clinical profile, the results of the randomized trials very shortly, and adverse events to be expected. And that's the first part of my talk. You see the structure of the molecule of brivaracetam. There were a couple of animal experimentations that show that it's active in a couple of models. There's strong seizure suppression in vivo in animal models of focal and generalized epilepsy. There's a strong affinity and selectivity for the SV2A proteins, and it's actually stronger so than as compared to levetiracetam. There's no effect at other targets such as sodium channels or calcium channels, and also not at the AMPA receptor, which are effects which can be exerted by levetiracetam, and that it is, sets it aside from levetiracetam somewhat. Also, it has a very rapid brain entry. If you give it IV, it will go to the brain faster than levetiracetam. That can be an argument to use it in emergency situations. This is the different trial results. You see each trial has a number here, and each trial has a color. So NO1193 is these yellow ones. So you see the initial trials had relatively low drug doses. Then you have other trials where they went up a little bit. For instance, NO1358. They did placebo as compared to 100 and 200 milligrams. And you see that placebo is pretty much the same in all these trials. Nowadays, we frequently have about 15 to 20% placebo effect. You see that the other drugs, the other doses have a significantly higher effect, and that led eventually to the approval of the drug in different markets. If you look at 100% responder rates as compared to baseline for secondarily generalized tonic-clonic seizures only, so that's just this most severe seizure type, then you see this graph, placebo 15%, with 50 milligrams you get up to 24%, with 100 milligrams this is now significant, 31% reduction, and with a 31% seizure freedom, and with 200 milligrams you have 42% that were free of generalized tonic-clonic seizures. And as you know, that's an important seizure type because you can injure yourself, and you can also suffer SUDEP if you have a lot of these seizures. If you have more than one of these seizures per month, your SUDEP rate goes up by the tenfold. So you want that seizure type to be controlled for sure. Let's look a little bit at the adverse effects from these randomized trials where you have rigid dose regimens that you had to adhere to. You see again placebo, the different doses here, and I marked the ones in red that were somewhat different from placebo. Somnolence had that in 8.5% under placebo, but 15.2% in the average of this, and you see a little bit increase with different doses. Vertigo, a little bit of a problem. Headache, you have it at all those levels, and so that doesn't seem to be associated with the drug. It's also 10% of placebo in the placebo group, and you see in the highest dose group was 7%. Then you see fatigue, nausea, those go up, and you see nasopharyngitis and irritability. So the red ones marked here are occurring in the dose responsive fashion. And you can inform the patient before you start the drug that this might happen, even though you see the percentages are not very high. There are some interactions. See here all the drugs listed many of the drugs listed we use nowadays, and you see here what the interaction potential is. You know, for the old drugs, carbamazepine, phenytoin, primidone, and valproic acid, they have substantial interaction potential. We have some drugs where there's none, gabapentin, lacosamide, levetiracetam, and brivaracetam has minimal interaction potential, so it's not quite as ideal as levetiracetam, but it's pretty near to levetiracetam. It can bring up, if you add brivaracetam to carbamazepine, the epoch side can go up. That's maybe the one thing one might want to know about this. So that's the best ones here, and brivaracetam is near to the best ones. How about the approval? This is obviously the German approval. It's certainly different in India. It was approved in Germany in February 15th, 2015 as an add-on medication for focal epilepsy. It's now approved for children as well, age 4 and above. It's available in Germany as tablets and as IV and PO solutions. So you can inject it in emergency situations, or if you want a rapid load. And otherwise you can give it as a kind of juice or solution, oral solution, for people who don't like to swallow tablets, such as kids, for instance. There's some uncontrolled post-marketing data published now, and maybe I'm talking to you today because some of these data come from my group, for the use in generalized epilepsy, for the use in status epilepticus, regarding the switch from levetiracetam to brivaracetam, and regarding the relative psychobehavioral adverse event profile, for instance, of these 3 drugs, which was an interesting study to look at. So which kind of questions remain after the randomized controlled trials? We want to know what's the long-term retention, what's the long-term efficacy in everyday clinical use. What do we know about the switch from levetiracetam to brivaracetam? And what are the psychobehavioral side effects? And I go into this a little bit by quoting to you the studies that were all made in Germany, so I know them best. The first one published on post-marketing use is actually by Bernhard Steinhoff from an epilepsy center near Strasbourg, so on the German side of the Rhine at the level of Strasbourg. And he studied 100 patients, 101 patients, and I sum it up here. 101 patients, 53% were females, they were all adult. It was done in a monocenter fashion and in a retrospective way, so they look back at their experience. Focal epilepsy, severely affected patients, median of 10 anti-seizure medications used, and failed before, so highly refractory population. Starting dose was 50 milligrams. The maintenance dose, on average, was 169 with a median of 200 and a range of 50 to 400. And that includes 14 patients that took more than 200 milligrams, which is usually considered the upper dose range, or the upper range of the approved dose range. 43% of patients were switched from levetiracetam to brivaracetam. That's still quite a common practice. Levetiracetam used to be the drug most frequently prescribed in Germany, so I suppose, let's say about 40 or 50% of patients with focal epilepsy were taking levetiracetam a couple of years back. And when you switch in this ratio either 20 to 1, so like 2,000 milligrams of levetiracetam to 100 milligrams of briv, or 15 to 1, and then you have 1,500 and go to 100, or you have 3,000 go to 200. There was an increased seizure frequency in this study in a couple of patients due to the switch, or after the switch. However, they also reported quite a few responders. The 50% responder rate was 28. Seizure-free was 7%, which is not too bad in this population. The retention after 6 months was 52%, and 30% of the patients who had discontinued for lack of efficacy, and in 3 patients they discontinued for side effects. And I mentioned the side effects from the randomized controlled trial. This was not so very different. Vertigo, somnolence, a little bit of ataxia. Some patients in this study had irritability, 4%, 2 had depression, and 2% had psychosis. That's the first post-marketing study published. Second one is from our group. You see the paper here, it's in epilepsia. This is Isabel Steinig. She's an MD student who did most of the work. She got all the data together, and it's a multi-center study from a couple of centers, including pediatric centers and centers in Marburg and other places. Again, the purpose was to evaluate factors predicting efficacy, retention, and tolerability of add-on brivaracetam in clinical practice. It was performed between February and November 2016, and the observation time, sorry about that noise, the observation time was between 3 and 12 months at the maximum. So we looked at 262 patients, and I go through the data in a second. 262 patients, 51% were female. Age range was 5 to 81 years. So some pediatric patients included at the time. It was from 3 centers, Frankfurt, Greifswald, which is in the very north of Germany, and Münster, retrospective nature, and 93% had focal epilepsy, 7% had generalized genetic epilepsy, and the prior number of anti-seizure medications used was 6.8, with a median of 6, so a little bit less than what Bernhard Steinhoff had reported, a little bit less refractory population. Our starting dose again was 50 milligrams. And again, in this case, 51% of the patients were switched from lev to briv. I think it was 43 in the other trial. So as you see in Germany, we frequently introduce brivaracetam by switching from levetiracetam. Ratio 10 to 1 in our case, or 15 to 1. So if the daily dose is 2000, we often switch to 200. And if the daily dose is over 2000, we also switch to 200 as an initial starter. Maintenance dose was 169 milligrams again, funnily enough. Median was 200, range was 52, 527 in this case had more than 200 milligrams. You see here the Kaplan-Meier curves for retention in the whole group. This is up to the 12 months. See that the retention was quite good, with 60% still taking the drug at 12 months. And then we looked at whether they were switched from lev to briv. It's the orange graph here, and whether there was no prior lev. And you see they behaved pretty much the same. In the end, the long-term retention was a bit higher in the patients that were switched, maybe because they had already some knowledge or that we had knowledge about the effect of levetiracetam in this population, and the reason for a switch was frequently tolerability, whereas it's usually patients in which we have observed that levetiracetam is efficacious. So the retention was 79% after 3 months, 76% after 6 months, 12% discontinued due to lack of efficacy, and 9% due to adverse events. In this case, the 50% responder rate was 41, so somewhat better than what Bernhard Steinhoff observed, I think because we used higher doses in general. And we had also a higher rate of seizure freedom, which was 15% as compared to 7% in that other trial. Somnolence was the reason, 16% vertigo and headaches, that was the side effects. Again, we also had psychobehavioral side effects. Similar to what Bernhard Steinhoff said, we had 4% of irritability. The same patients were aggressive also, and we had 9% of depression. And when we switched due to levetiracetam side effects, we used to do that mainly for somnolence. So patient had efficacy, but they were kind of tired under the drug, and the somnolence improved in 71%. It was worsening in only 8%. So if the patient is tired under levetiracetam, it's a good reason to switch to brivaracetam. And regarding the psychobehavioral side effects, that's another frequent reason. We switched 35 patients were switched from levetiracetam to brivaracetam because of psychobehavioral reasons, and 20 of those, so 57%, improved. We had also 2 patients that worsened, so 6% got worse after the switch. Interestingly, we had the chance, by looking at these 262 patients, is psychobehavioral, the presence of psychobehavioral adverse events under levetiracetam, is that predictive of having psychobehavioral side effects under brivaracetam? So we have 2 groups of 100% here. The disease had psychobehavioral side effects. The other group did not have psychobehavioral side effects. And now you can see after the switch, how did this evolve? So out of those 100 with psychobehavioral side effects, we had 23% that still had psychobehavioral side effects under brivaracetam. Whereas in the group that did not have any psychobehavioral side effects under levetiracetam, we were quite sure that this would not occur under brivaracetam. So only in 8% such side effects occurred newly. Third study is from a group in Marburg, and they looked at their own first experience, similar to the other two studies. A little bit smaller patient number, 93 patients with 38% female, monocenter retrospective. Most patients had focal epilepsy and only a very small percentage had generalized genetic epilepsy. Similar, otherwise similar cohort as compared to ours, with only 6.3 anti-seizure medications used before. They had a median of 100 milligrams, and again, the switch was in about half of the patients was the case. They didn't report how they switched, and they reported efficacy, 35% of 50% responders, 9% seizure-free. Retention was 72% at the mean follow-up of 5.3 months, and 15% discontinued due to lack of efficacy, and 20% due to adverse events. Side effects, again, somnolence, some complained about cognitive problems, and 3% about vertigo. Again, irritability, aggressiveness, and depression was also present in a minority of the patients. Patients that had adverse events under levetiracetam in the past or at the time of the switch, in those patients, together it's about 50 patients, they reported an improvement or no recurrence after the switch. 77% of these 50 patients improved after the switch. So in overview, you see the three studies here. Sorry, it's actually some of it is still in German, but I think you can still read it. You see the switch was 43%, 51%, 51%. The responder rates were 28, 41, 35. So remember, 35 is an average. Seizure-free was about 10 to 15%. Adverse events you have heard already. It's nearly the same with somnolence, vertigo, and a little bit of irritability in some patients. We recently, just this year, we were able to publish another paper in epilepsy, which again is by my deputy head here of the Epilepsy Center, Adam Strelzig. He's the first author. And we look now at these 262 patients from the study which I reported to you before, which was where the first author was Mrs. Steinig. And we looked now a couple of years later. Mean age was 40 years, the range again, 5 to 81, 129 women. Most had focal epilepsy, some had genetic generalized epilepsy, some others or unclear epilepsies, or unknown epilepsies. Only 26 of these patients had never received levetiracetam, 133 were switched from levetiracetam, and I mentioned that before. The length of brief exposure was now 1 day to 5 years, with a median retention time of 1.6 years, so much longer than before. Total exposure was 6,029 months, so 569 years, so that's quite an experience in quite a lot of patients. Retention rate was 61% at 12 months, with a 50% responder rate of 31%. I mentioned again, it was about the average of the three trials that we looked at before. Mean dose at last follow-up was 222, so it was somewhat higher as compared to these acute trials where it was 169 or so. And again, the range was 25 to 400, including 52, that is 39% who exceeded 200. So as you see, we often times in Germany we give a little bit more than 200 milligrams, up to 400 milligrams. Yeah, if you had fewer concomitant anti-seizure medications, so rather than having 3 other anti-seizure medications, you only had 1. And if you were switched from LEV to BRIV, you had a better short-term response. But none of these parameters we looked at were correlated with a positive long-term outcome. BRIV was discontinued in 24% due to insufficient efficacy over these 1.6 years on average. In 29 patients, so 11%, it was discontinued for psychobehavioral adverse events. and in another 10% for other adverse events. See here the data from that trial, which again was published this year. See, seizure-free, this is at 12 months here. At 6 months, I suppose it's enough to look only at one of these graphs. You see seizure-free, 10%, 50 to 99% seizure reduction, 20%. Lesser reduction was only noted in 5%. No change was about, again, 20%, and a little bit increase in seizure frequency was about 4% or so. This was discontinued, or we didn't have data. You see, this is the study in the form it appeared in epilepsy, and the key points really are long-term post-marketing data from brivaracetam now available for these 262 patients, showed a relatively good overall retention rate of 58%. At 12 months, the 50% responder rate was 33%, with 10% or 11% reporting seizure freedom. Previous treatment with levetiracetam did not impact the retention. So if somebody was switched, didn't change his retention. So if patient had been on levetiracetam and you thought they didn't do so well, that should not preclude you from giving him brivaracetam. No long-term efficacy predictors could be identified. Right, now we come to the special patient groups. That's patient with handicap, encephalopathy, with genetic generalized epilepsies, and with status epilepticus, and I was told that may be of interest to you as well. There's obviously much less data on these groups. Let's start with a small study from Dr. Kerling and Dr. Winterhöller and Mr. Andres, which looked at a relatively small cohort of patients with behavioral changes or intellectual disability. That looked especially, did these patients develop behavioral changes under brivaracetam? Only an N of 33, so a small number, 42% were female, age range 17 to 63 years. It was done at one center, which is called Rummelsberg. It's near Erlangen. It's a center for patients with mental handicap and cognitive problems. So all adults with cognitive disability. They had a minimum of 6 anti-seizure medications in the past, and they were currently taking a median of 3 anti-seizure drugs. Some were obsessive compulsive to start with. Some had affective disorders. 2 had psychoses. 2 had autism spectrum disorder. So that's quite a severely affected population. A switch from left to briv was done in 8 of these patients. That's 24%. And the dose aimed for in responders was 200 milligrams. So they switched them, they checked out, do they respond? And if they responded, they tried to reach 200 milligrams in these patients. So that they had a good range of 50% responders, 9 out of 32, 28% after 6 months. And they had, unluckily, nobody who was seizure-free. And after 12 months, this didn't change too much. The responder rate went somewhat down. Retention was 56% after 6 months and 37% after 12 months. So somewhat lower as compared to the other epilepsy population without cognitive problems. They had adverse behavioral changes in 13 patients. So that is more frequent as compared to the population that is not affected by these cognitive problems. And especially in patients that already had psychiatric comorbidity. And in 8 of the 32, brivaracetam had to be discontinued. But you can see even in this highly problematic population with mental retardation and behavioral problems, the drug is quite useful. Now there's some data on, again, from Adam Stelzig, from our group, there's some data on patients with generalized genetic epilepsy. It was an N of 61, so also a relatively low N because, as you know, it's not approved for that population. 67% were female, age was 9 to 90. Multi-center data acquisition from Berlin, Frankfurt, Greifswald, Cork, Marburg, Münster, Neuruppin, so that's 7 sites. And the study was retrospective. 26% had juvenile myoclonic epilepsy, also called Jan's syndrome. and 7 had childhood absence epilepsy, and 59 had other non-defined or not specifically defined epilepsies with generalized genetic epilepsy. Drug resistance was given by this number of anti-seizure drugs, which was 4.3 that had been used previously. So it's a little bit less than we had with the focal epilepsies, and that's frequently the case in generalized genetic epilepsy. Obviously, also you have less drugs available which you could choose from. It's another factor. This is the drugs that were taken: levetiracetam, lamotrigine, valproic acid, topiramate. We had a switch again from left to briv in 51% of these patients, so in about 32 patients. And the maintenance dose was an average 180. The median was again 200, and the range was again 50 to 400. So we use it the same way in generalized epilepsies as compared to focal epilepsies. You know this graph already. This is the retention over 356 days, so a year. And again, whether they were switched or not switched didn't really do much change. Maybe a little bit more better long-term retention is in those that were switched. And you have a long-term retention of 12 months in about 56%. So a little bit worse as we have observed in the focal epilepsies, but there was a good retention. See that here. We looked at efficacy. We had 36% of 50% responders, 50% responders. We had seizure freedom in 25%, albeit it has to be said that I think 2 of these patients were seizure free before and were only switched because of side effects with levetiracetam. So 50% responders at 6 months, 28%, at 12 months, 23%, which is somewhat worse as compared to the focal. But one group sticks out clearly. And the JME patients, and you know that levetiracetam is approved for add-on use in JME patients that did not become seizure-free under valproic acid. So similarly, it seems to be the case that brivaracetam is quite useful in JME patients, and you know they can be very difficult to treat. So we had a 60% responder rate here, and 40% of these patients were seizure-free. So that seems to be a particularly good group to treat with brivaracetam. Whereas the childhood absence epilepsies, I know it was not very many, and Jevon syndrome, they did not respond in our experience, but obviously small cohort. We did not treat with valproic acid, and we had some somnolence, some irritability, and some depression. Again, in this population, quite similar to what we observed in the patient with focal epilepsy. I will now look a little bit in the IV use, because one of the advantages of brivaracetam is that you can also give it intravenously. And we have a little bit of an interest in status epilepticus treatment, and we have looked at all these drugs. You looked at some of the problems with these drugs, and what you want if you give a drug rapidly IV, you want that it doesn't do respiratory depression, and that is true for these 4 drugs, including brivaracetam. You don't want circulatory depression. That's again true for valproic acid, levetiracetam, lacosamide, and brivaracetam. You don't want too much of an effect on vigilance. Somnolence can occur. Sorry for not translating here, but the word is quite similar to the English word. You don't want interactions, minimal interactions. I mentioned that before. The half time, that doesn't really matter too much, but this is a good half time for a drug that you want to give IV. You can change levels and stop it, and then it will fall off after a relatively short while. Do you need drug monitoring? No. Do we have tissue toxicity? You have some tissue toxicity in phenytoin, as you know, quite high. In valproic acid, you are meant to give it strictly IV. It's quite toxic if you give it paravenously, and the toxicity, the local toxicity appears to be quite low for brivaracetam again. So looking at the green in general, it looks quite good for brivaracetam and some other of the newer drugs for IV use. So we have some data on brivaracetam in status epilepticus, and be aware that this is not approved for the treatment of status epilepticus, so it's really, it's you can't blame the company, blame it on me. We used it sometimes in status without it being approved. That needs to be considered. Ends are not very high. You see 11 here, 7 and 2, so very small ends. Most of this was retrospective. This was from Salzburg in Austria. This is from Frankfurt. This is Frankfurt and Greifswald together. Many had structural epilepsy. 2 had refractory status epilepticus, and 3 had super refractory status epilepticus. So going on beyond 24 hours, even though you have given them something, or if you gave them something, they responded, and you would discontinue the drugs, the status would reoccur. That would be the definition for super refractory status epilepticus. This is what we did, or what they did. Bolus dose of 150 milligrams, in average, a median dose of 100. Here was bolus was a median of 100 again, and here was a bolus of 300 or 200 and 200 in 2 cases. Efficacy was defined as you didn't have to give another drug after brivaracetam, and that was the case in 38% of the refractory status cases, and none of the super refractory responded. And the group from Austria with a smaller N reported quite good response, and again, we had not such a great response, but it is a choice. It is tolerated very well. It's unproblematic to give it. You know that we now have a prospective controlled trial with levetiracetam, where levetiracetam was as good as valproic acid or fosphenytoin. We would assume that this similarly will pin out similarly for brivaracetam, with one difference: brivaracetam goes to the brain faster, so you would expect that it works a little bit faster if it was given early on. But usually these trials start in a population that is highly refractory, as in this case, and then people get more daring, and then they use it in patients at an earlier stage. I was asked to give you a couple of case studies to show you how we use it in our personal experience. This is one of the use cases. It's a patient born in 1987. He comes for pre-surgical monitoring with daily seizures since the age of 1. Etiology is unknown. He has an atypical Lennox-Gastaut syndrome. He has a right arm paresis. His medication, when he comes to the unit, is levetiracetam 2,000 milligrams BID, so a total daily dose of 4,000. Lacosamide 100 milligrams BID, so a total dose of 200. Valproic acid 1,000 milligrams BID, so a total dose of 2,000. So that's quite a high drug load. During the monitoring, we tend to reduce drugs. So in this case, we reduced levetiracetam to 2 times 500. We recorded 8 seizures from the right hemisphere. The patient was discharged on brivaracetam. So he was one of these patients where we did an immediate switch, and that's how we usually do it. When I switch, I give them the morning dose with levetiracetam, then I give them the evening dose with brivaracetam, and next day they are completely on brivaracetam with the exchange dose of 1 to 10 or 1 to 15, a little bit depending on whether I want to get rid of side effects or whether I want to increase efficacy. Yeah, this is just specific for the case, which are not so important. Second case is a dentist. I was asked to think a little about my monotherapy cases, and he's born in 1972. You don't want to be in the care of a dentist with a focal epilepsy, certainly if it's not controlled. He had a structural epilepsy. He developed it only at the age of 47, so a few years ago. He had automotor seizures 2 per month. He's currently seizure-free, and he had generalized tonic-clonic seizures only once. So that's what you want from your dentist. You want him to be well controlled. Epilepsy type was left temporal lobe epilepsy. Etiology was a low-grade epilepsy-associated tumor, LEAT, left temporal pope, so something that you could operate on. However, he was seizure-free, and he didn't think it was necessary to get brain surgery for this condition at this time. He had a couple of allergies, so you would be scared to give him something like lamotrigine. The history of mild depressive episode. He works as a dentist. He's married with 2 kids, and he's currently on levetiracetam, which was his first drug ever given. And under this medication, he is irritable and he feels anger, and that's not good for the patient care, and it's also not very good for his private life. So his wife thinks it's a little bit more problematic to be with him when he's always irritable and not so mood stable. So so he was switched. It was switched from Lev to Briv, and things improved. And we switched within 1 day, and we went from monotherapy with levetiracetam to monotherapy with brivaracetam, which is off-label again, but it works. So in general, my impression of brivaracetam is it's a younger sister of levetiracetam, obviously quite closely related, but more benign and easygoing. Has a higher affinity to the SV2A protein, goes faster to the brain. It has, in my experience, the same efficacy and a better tolerability. Actually, it has a little bit better efficacy because you saw the 50% responder rate, even those that were switched. So even the ones that are switched have a little bit better efficacy. And you can also go up it a little bit more because it's better tolerated. We use it, or one of the use cases is in patients that had good efficacy under levetiracetam, but they had psychobehavioral side effects or were very tired, like our dentist. He would be a pretty perfect person to switch him. Seizure-free under levetiracetam, but adverse effects, so get rid of the adverse side effects by the switch. Switch from one day to the other. Day 1 comes into the office, 1500 Lev in the morning, 1500 in the evening. Day 2, 1500 in the morning and 100 Briv in the evening, so ratio 15:1. And day 3 already on 2 times 100. Then you can always assess, is he much improved with his side effects? If he is doing well seizure-wise and he has some side effects, you can go down to 2 times 75. But if he has no side effects anymore and has some seizures left, then you could up it to up to 2 times 200. And we will do that in a stepwise fashion. Up to 200 BID. That we rarely use more than that, I must say. It has a little bit more interactions, I mentioned, especially if you have carbamazepine on board, the epoxid can rise and the patient can be therefore more tired. So that's something to observe. If you have a patient on carbamazepine, you give him brivaracetam, he gets tired. It's not because of the brivaracetam directly, but it may be because the epoxide goes up, and that should be measured then. And I mentioned that we use it in JME, juvenile myoclonic epilepsy, because we have seen it's quite effective in that condition as well. Let me go to the last part of my talk. That is perampanel approval in GGE. I heard from your colleagues that you have perampanel in India. It's been approved for a while, same in Germany. And it hadn't been approved it had only been approved for focal epilepsy as an add-on medication, especially in pharmacorefractory population. But it's now been approved in pharmacorefractory generalized tonic-clonic seizures in genetic generalized epilepsy as well. The trial was published by Jackie French in 2015, and I think in 2016 or 17 it became available as a treatment on the market. We had relatively few options for generalized genetic epilepsy, as I mentioned. Monotherapy, we have valproic acid, lamotrigine, and perampanel. As add-on, we have levetiracetam and the topiramate. As an add-on, we have levetiracetam and perampanel. And since 2017, it became available in Germany. And we usually give 2 to 6 milligrams, but the maximum allowed dose is 12 milligrams. Usually in this range, you have good tolerability. If you go a little bit higher up, you can have vertigo. So what did Jackie French and colleagues do? They studied 162 patients with refractory, primarily generalized tonic-clonic seizures in patients that had clear-cut GGE. So they had EEGs from all of these patients, and they were all checked by Jackie French and her team centrally. So we are quite sure that these patients actually had genetic generalized epilepsy or idiopathic generalized epilepsy, which is the old term. It was placebo-controlled. They had a baseline, and then they had a 13 weeks treatment phase, and they looked at the reduction of generalized tonic-clonic seizure. And interestingly, even the placebo arm, this went down by 39%, but significantly more so under perampanel, 77%, or nearly 80% reduction of generalized tonic-clonic seizure. And freedom, sorry for the S, freedom of generalized tonic-clonic seizures in 12% under placebo and 31% under perampanel. You see the graphs here on the right side. Come to my summary. So for rivaroxaban, you have good tolerability and retention. You have a good 50% seizure reduction between 28 and 41% in the randomized trials. And for instance, 39.5% under 100 milligrams per day. Seizure-free was in 7 to 15% in the post-marketing experience. The switch from left to BRIF is quite well tolerated. We use a ratio of 10 to 1, sometimes 15 to 1. I showed you that some people use 20 to 1, but I think this is now the most frequent ratios that you switch. For instance, left 1500 to BRIF 100. This leads to an improvement of psychobehavioral adverse events following the switch from left to BRIF in about 60% of cases. It's a therapy option in patients with disabilities and with generalized genetic epilepsy. Yeah, it's not approved again, but in our experience that seems to work. This is experience from the group in Rummelsberg. This is 33 patients, and this is from the study and 60 patients with generalized genetic epilepsies. There's very limited data on the use in status epilepticus, but it's obviously increasing now over time. It's not approved, and it's obviously not recommended by any guidelines because it's too early. In the epilepsy textbook by Pete Engel and others, there will be a chapter on rivaroxaban, which is mainly by Bassel Abu Khalil, but I was also allowed to contribute a little bit, so that's going to come out in a few months, I suppose. And regarding perampanel, you should know that it's an AMPA receptor blocker, competitive AMPA receptor blocker. It has a long half-life, once daily dosing. It's approved for add-on in focal epilepsies and now also in generalized tonic-clonic seizures and genetic generalized epilepsies that persist under the other medications. Vertigo and psychobehavioral side effects are noted here. And with that, I thank you very much and provide a little view at night because it's getting dark over here now. This is what Frankfurt looks. It's the only German city that has some decent skyline, so you are welcome to visit. And when you come by the airport, try to make it into town. It's actually quite nice. Thank you very much for your time and attention. Thank you very much for your time.
Yeah, it was nice talk.
Thank you.
So yeah, really nice talk. So Dr. Sanjeev Thomas, now you can proceed for the panel discussion part, sir. Yeah, it was nice talk.
Thank you very much, Professor Rosenow, for the excellent presentation on the status of rivaroxaban and perampanel. There are several questions on this topic. However, before going into that, I would like to have the panel's opinion on some of these aspects and how we have been using it. I must apologize for incompletely introducing the panelists at the beginning. I had a problem with my slides, and the first of the panelists is Dr. Manoj Gulane from Nashik. He is a senior faculty, and he had been He has graduated from Nagpur Medical College and is working in the city of Nashik. I have a question with this. When do you consider brivaracetam in your clinical practice, or when do you think it will be fitting in our Indian situation? Can I get the comments from Dr. Manoj, please?
I think all of us started using brivaracetam from last 5 years. The first indication we had all of identified those subgroup of patients having problems on levetiracetam. So that was the introduction of Brave in Indian market as well as in the world. Those who can't tolerate Leo, please replace with brivaracetam. Days went on, we realized that brivaracetam is working well, behavioral side effects are less, and we continued it with. And in my personal opinion, suppose my patient was on lacosamide and levetiracetam, I added Brave. Gradually, I saw that couple of years seizure free. Then I tried to reduce lacosamide from whatever dose he on, and I actually many of us succeeded on keeping patients at the end of couple of years trial on monotherapy brivaracetam. So this is one aspect of the. Second aspect, I have been always stressing in so many brivaracetam talks we do over all this COVID lockdown period is already been expressed very nicely by Dr. Felix. That is, I started somehow using it in my chronic epilepsy. Everybody has a problem, valproate induced obesity, PCOD, hair fall, then come levetiracetam, lamotrigine is not tolerated so well, then what to do? What to do? Then many of us added brivaracetam first, and gradually what I noticed that actually I could taper down slowly sodium valproate and some other drug like clobazam or even phenobarbital. And now I dare to put, after a long discussion with the patient, most of them fortunately are fairly educated and now internet savvy. I give them time in waiting room to read about two drugs, valproate versus brivaracetam and levetiracetam, and try to generate confidence that, well, you have a trial on valproate, become seizure free on in juvenile myoclonic epilepsy, and slowly we introduce brivaracetam. This is how I have tried to change the scenario to avoid the toxic adverse event profile of sodium valproate and change over to brivaracetam. Most of my clinical practice has seen a drop of around 40% prescriptions of levetiracetam. Those who are tolerated, we didn't change. But when I felt that I need to add something more, second add-on, levetiracetam, I always give them a choice of brivaracetam now. Even means a neo patient for brivaracetam, not necessarily levetiracetam exposed. This is how I look at it. This is how I have been doing it recently over the last couple of years. Thank you.
Thank you, Dr. Manoj, for that insight into the way you are handling the newer drugs. And I have a similar question to ask in a broader way. And we have several newer anti-epileptic drugs in the last few years. And how do we choose between these newer anti-epileptic drugs for a given patient, especially when they are coming to us as a new patient? I would like Dr. Meenakshi Sundaram from Madurai to respond to this question based on his experience and what he considers will be an appropriate approach. Dr. Meenakshi had done his neurology from NIMANS and is practicing in Madurai. He has several publications and has won several gold medals and best paper awards during his career.
Namaste, sir. So thank you for the invite first, sir. Thank you very much, Ankan, for the opportunity to be with all stalwarts on the same platform. Thank you very much once again, sir. Am I audible, sir?
Yeah, please go ahead.
Now your question is, how do I choose the anticonvulsant, whether it is new or old?
No. Between the newer anti-epileptic drugs, we have the perampanel, we have a brivaracetam, levetiracetam, and several other drugs also, which are relatively very new. And then we have the older generation drugs, very or not very old, like carbamazepine, valproate, other newer drugs.
There are only two things which dictate our practice. The first is, what is the epilepsy syndrome we are trying to treat? Whether it's a generalized or a partial epilepsy and they're having some syndrome behind this, and which one will be the most effective agent. That's the first one which is going to dictate our practice. The second thing which is going to dictate is how expensive it is on the long term. If I'm going to plan a drug for 2 years, then let me sit and calculate the money the patient is going to spend. And third is how I'm going to really monitor this patient. What is the education level of this patient? How am I going to accept the adverse event profile in these medications? I do a matching of all these data and then come to a conclusion which molecule will be useful for the given patient. So that are the three things. One, how the epilepsy syndrome. Number two, cost. Number three, acceptability. Four, adverse event profile. All these things matched together, I come to a conclusion which medication could be quite useful. Of course, the issue of approvals also remain, but I have a certain question to ask Sanjeev sir and the elite panel here. For instance, our respected speaker also spoke about the use of levetiracetam. What is puzzling me, and can I put it across, sir? There is some puzzle. I am always, puzzled about one important information here. Let me put that puzzle. I am understanding that brivaracetam has been approved for monotherapy. And may also, when I read about it, it says that levetiracetam as yet by the US FDA or by DCGI not yet approved for monotherapy. How is it that most of us are using levetiracetam as monotherapy when it is not approved? And how come brivaracetam has got a monotherapy approval when levetiracetam is yet to reach that? I would like to really put that across to his parents. Sir.
Right. Dr. Meenakshi, thank you very much for bringing in that the angle of the cost of treatment, which is very important from Indian context, because most patients have to meet the treatment from their own personal savings, and insurance or the government subsidy is very limited in this country. Regarding the licensing part, Dr. Nitin, would you like to comment on the licensing part of brivaracetam? Okay, Dr. Nitin is probably not available. The licensing part of it is actually a different story altogether. It is based on the what the institutions or the pharmaceutical companies put forward to the licensing authority, and rather than what is the best thing. So if somebody is putting forward and based on the literature and the Indian data, they might give license or they may not give license. But it is not a initiative that comes from the licensing authority. That's the way I look at it. It depends on who is pushing for the license.
Are we legally correct if we use it even if it is not within quotes approved, sir?
What is the permissions for using a medication off-label? This question, it's a gray area, I would say. Nevertheless, there is a scope to use a medicine for off-label purposes after discussing and situation requires. Like if there is a urgency or a life-threatening situation, and there are off-label evidences, I think there are permissions to use off-label uses. But by and large, we are supposed to stay within the licensing principles.
Thank you, sir.
There is another aspect of treatment, which is the comorbidity and the vulnerable group, women, elderly people, and how do we see the newer anti-epileptic drugs from that viewpoint? I am for addressing this question to Dr. Shivakumar from Bangalore. Dr. Shivakumar has done his neurology from Sri Chitra Tirunal, and he has also done his fellowship very successfully, and has a long track record of winning several awards and best paper awards, and he had been a bursary recipient of the Young Scientist Award at the World Congress of Neurology and so on. He is now practicing in Bangalore. Dr. Shivakumar, would you like to comment on this aspect of newer anti-epileptic drugs, particularly brivaracetam and perampanel, on the vulnerable groups use?
Thank you, sir. And I thank the organizers for giving me an invite for this August forum. And I thank Dr. Sanjeev, sir, who is my teacher, and to share with him the podium here. So the comorbidities, what we commonly see in children, particularly the pediatric age group, is the behavioral problems and the cognitive problems. And we see a lot of cognitive problems in the elderly, and we see a lot of cognitive problems and psychiatric problems with levetiracetam also. So basically, initially we started using brivaracetam for people who had a lot of psychosis or psychiatric related issues, and we were trying to take off levetiracetam, assuming that brivaracetam is going to solve the issue. To some extent, brivaracetam has been good in controlling or reducing the psychiatric or the behavioral problems, but in fact, we had a little bit of issues with brivaracetam also, where we had to go back to levetiracetam also. So overall, brivaracetam has less side effects on cognition, behavior when compared to levetiracetam. So as of now, in my clinical practice, I use only for focal epilepsy, either as a monotherapy or an add-on therapy. And in some cases of generalized epilepsy where they are not tolerating levetiracetam, we are adding brivaracetam, which is as a indirect choice rather than directly choosing this drug at this point of time. And it's working well for the genetic generalized epilepsies also, sir. So basically, I would like to say cognition, behavioral problems, and someone who is having a lot of comorbidities where there's a lot of interaction with medical conditions, this drug would be very optimal for us to use in clinical practice.
Thank you, Dr. Shivakumar, for the insight. Another aspect which we have been doing was specifically with relate to perampanel, and I would like to address this question to Dr. Ashish Datta from Kolkata. He is a senior consultant in neurologist in the Institute of Neurosciences in Kolkata, and has done his graduation and post-graduation from the Institute of Postgraduate Medical Education in Kolkata. He has won several awards and prizes, and first rank in medicine and DM and MD medicine, and he has an excellent track record. Dr. Ashish, would you like to say why do you want to use perampanel, or when do you would like to prefer perampanel in your practice?
Thank you for giving me the opportunity. I think I'm audible, sir. So,
yes.
So in perampanel, I use in some special situations. Particularly, I choose this molecule when I look into a person who comes with a focal seizure and who also have particularly the secondary generalizations, and the person is not on any enzyme-inducing drugs, and particularly who are MR negative epilepsy, means where the etiology is not very well discernible from imaging point of view. So imaging negative focal epilepsy with secondary generalizations, and I add on particularly when the person is not on any enzyme inducing drugs like carbamazepine. So this set of group of patients I found to be effective for adding perampanel as an add-on. And other groups, like I would say few people with like that of a progressive myoclonic epilepsy, so PME group, there this perampanel works as a better. We have experience of using perampanel in super refractory status as a loading through Riles tube in only 4 patients, I would just say. And in 2, we had a good response with that, but in the another 2, we did not have good response. So I would just say that in 3D's context, particularly when we're adding up as a first add-on in MR negative epilepsy with secondary generalizations and without any enzyme inducing drugs, in few situations of progressive myoclonic epilepsy, PME group, and in persons with a super refractory status epilepticus as a loading dose through Riles tube. These 3 situations I found to be perampanel as a good, and particularly also as a professor was telling us, Professor Felix, yes, in refractory generalized epilepsy, like those things, that is a subgroup where we can think of using it. That way, sir, I looked into it, sir.
Yeah. Thank you very much. I would like to now take up the questions from the audience, and there are several questions that have come up, and I would like to address these questions to Professor Rosenow, who has the largest experience in this field. The first question is from Dr. Rahul in Nagpur. Can brivaracetam be used as the first-line drug, anti-epileptic drug, in case of new onset seizures?
Well, I think it's not approved in Germany for that use, so I wouldn't usually try to do that. So the situation I mentioned with the dentist would be probably the one where we would use brivaracetam relatively early on. Otherwise, it's for add-on, and I personally like to add it on to a sodium channel blocker. So if the patient has already had a sodium channel blocker and doesn't respond to that one alone, then I would, for instance, add brivaracetam, and that could be the second drug. But as a first drug, as it's not approved, I'm not too inclined to use it. I suppose in the future that can be done as soon as we have approval. I would have no hesitation to use it in that way, but in the moment we hardly ever do that. But that's approval status.
Thank you. Another question is from Dr. Babu in Vizag, and this is about the safety of brivaracetam, and also another person has also asked about perampanel in pregnancy, specifically pregnancy and lactation. Do you have any experience in this area, or?
No. We heavily rely on the Europe registry. I think India is also part of that registry, which is, I think it's now the best registry worldwide, probably because of your tremendous contribution to that one. And they don't have enough data as of yet. It always takes a couple of years, and I was very glad when we had the data on levetiracetam. So if a person on brivaracetam now says, I want to plan pregnancy now and I want to become pregnant, I tend to switch them back to levetiracetam if they can tolerate that. And because it's just, we have the better data for levetiracetam, and it is a little bit different regarding pharmacokinetics. So I wouldn't be able to predict what might happen to the fetus from brivaracetam based on the data of levetiracetam. So I would switch back.
That's correct. The registries which are looking at the birth defects or neurocognitive adverse effects of use of anti-epileptic drugs in pregnancy have not yet published any data on this matter. There is one publication from Torbjörn Thompson, who is chairman of the URAP, and from Australia. So that is about 90 pregnancies in women who were taking perampanel. And this is not part of the registry, but outside the registry. And there they have noticed that there had been a good number of fetal loss, and also one case of a cardiac malformation which has resulted in a stillbirth. They have, in that publication, they have also mentioned about the fetal loss, increased fetal loss in rat studies, and neurocognitive problems in these rat pregnancy outcomes. So there probably need to be a little more caution about the use of these medicines in the pregnancy, and when we do it, it's very important that we systematically gather information at least 100 pregnancy outcomes. If we have in good quality data, that will be the beginning of a good amount of the. Nevertheless, I would imagine that because brivaracetam is a molecule which is very close to levetiracetam, it should probably have similar profile as levetiracetam. But with regard to perampanel, we probably may have to wait and see how it turns out.
Yeah, we tend to be quite conservative. As we now have a couple of drugs where we have very good information, I would tend to be very cautious about perampanel and also brivaracetam at this point in time.
Dr. Ajit Cherian has asked a question about the use of perampanel in absence seizures. Do you have any data or any experience in that area?
Yeah, we published these two papers where once was an absence status and it didn't work in that case, and then in the study with the 60 patients that I presented, it didn't seem to work very well in childhood absence, but it was a relatively small n, and also in Germany we had 1 or 2 German syndromes, and it didn't work very well there either. So regarding generalized genetic epilepsy, I think I would be most inclined, and I actually do that, to use it in JME. That seems to be juvenile myoclonic epilepsy, seems to be the syndrome where it works best. Whereas the other ones, we don't have sufficient data to support efficacy as of yet.
Yeah, I think Dr. Mohammed Kunya, would you like to comment on this? You have also vast experience in the pediatric epilepsy. I do not know whether he will be able to answer this question, because he is it possible to upgrade him to the panel and then get his comments? While that is being done, I will go to the next question. Dr. Surekha has asked from Jaipur, between what would be the difference, or how will you choose between brivaracetam and perampanel?
Yeah, for me, they're both valuable drugs, but I suppose given the fact that we use so much levetiracetam in this country, I certainly use brivaracetam more frequently and probably at a little bit earlier stage in the treatment setup. I do use perampanel, but I use it at a little bit later stage, and whereas Briv would be perfect choice for second treatment or for first add-on, I probably use perampanel a little bit later on. Why should that be the case? I think it's because of the issue with vertigo if you go higher, and it's also it's from the psychobehavioral standpoint, it is a little bit more complicated. Yeah. So for me, it's a little bit later on. It's highly effective. The good thing is it's a completely different mechanism of action, but for the initial few drugs I use, it may be number 4 or something like that, whereas brivaracetam may be number 2 or 3 that I use.
There are several questions about the use of perampanel and brivaracetam in the status epilepticus. Again, I would say that this has the licensing may not mention this specifically, so its use has to be considered as an off-label situation with its own limitations. Based on with that understanding, Dr. Felix has already given a good amount of data on the use of these drugs in status. Would you like to make any final comments about it?
Yeah, we were most impressed. We used it actually, probably were one of the first to ever use it in status in a lady with progressive myoclonus epilepsy. And Dr. Manoy also mentioned that. And in that case, we thought maybe we finished treatment at all and stop ventilating her and so on and so on. Then we added, starting with 12 milligrams of perampanel, and she left the hospital walking. So in that situation can be highly efficacious. And so I suppose we certainly need more data for progressive myoclonic epilepsy. And I would be, in such case, I would feel very inclined to use it. We also looked at a series of patients where we started in refractory status epilepticus, but that is usually, these data can usually best be used for tolerability rather than for efficacy, because at that late stage of status, no drug does very well. So I think it's well tolerated. It obviously needs to be given PO. So we tend to start with very high doses of 8 or 12 milligrams, sometimes more, because it has such a long half-life, and it will take a couple of half-lives to come up to the efficacious level. So if we use it usually quite late in status, and we start relatively high with 12 milligrams or so.
That's right. Thank you very much for that input. These are the questions which were from the audience, and I would like to say that we had a wonderful evening with a lot of the audience. And
can I have one question, sir?
Yes, please. I would like to say that we had a wonderful evening with a lot of the audience.
So there's a curious question once again, sir. This concerns the pharmacology. So could you just teach us as to how come brivaracetam, we say it is bereft of psychiatric manifestations because it doesn't touch the AMPA receptors on one hand, and then we have a molecule entirely dedicated to AMPA, which is perampanel, both of which were discussed today. What is that in the pharmacology which differentiates these two mechanisms, sir?
I didn't quite understand. Can you repeat it again, the last part?
The brivaracetam, as compared to levetiracetam, we are told that it doesn't touch the AMPA receptors. AMPA receptors are free, and that's the reason why it does not have adverse effects in terms of behavior. This is on one hand. On another hand, we have a molecule which entirely acts only on the AMPA receptors, which is perampanel. These were the two molecules we discussed. So what does it talk about it in this pharmacology, how these two are different?
Yeah, I mean, that's an argument that's made because brivaracetam has very low affinity to the other receptors. It only goes to SV2A and has very little affinity to the other receptors, where levetiracetam seems to exert some action that has been used as an argument that there might be a clinical difference in side effects. This is just one possible explanation. I'm not sure whether I put too much weight on these pharmacokinetic ideas, because in the end you will you will have to make your own judgment. You get a drug to the clinic and you start making your own judgment about this, and you feel more and more safe and know when you want to use it. But I would not put too much weight on these subtle pharmacokinetic and pharmacodynamic arguments. Yeah. Sorry, I'm not a scientific user, but I'm just more a clinical user in these drugs. As soon as they come to the market, I'm quite interested and use them as much as I can initially to get an impression. And that impression is that brivaracetam is better tolerated than lev. Why that should be the case, obviously that's one possible explanation, but yeah, I'm not so sure. I rely more on the clinical judgment.
Thank you, sir.
Well, we had a very interesting discussion, as well as the inputs from the panelists to supplement a wonderful talk from Professor Rosenow. And this evening we had a lot of information on the two new drugs and its place in the management of epilepsy. With this, I would like to complete this panel discussion and the question and answer session, and hand over the session back to the Alcom Medicals. To lead this panel discussion.
Thank you, Dr. Sanjeev, and thank you all the panelists for making this session lively. So along with me, we are having SBO head, Mr. Suman Singh, who is going to give a vote of thanks for making this session lively. So, we are having SBO head, Mr. Suman Singh, who is going to give a vote of thanks
Hello, yeah, good evening, sirs. Thank you all for being a part of this wonderful international speaker program. At the outset, I take this opportunity to thank all our moderators, Dr. Sanjeev Thomas, for bringing all the relevant points into the discussion, and our panelists, Dr. Manoj Gulane, Dr. Shivakumar, Dr. Minashi Sundaram, and Dr. Ashish Datta for sharing their views and personal experience and answering all the questions received from the audience. I would also like to thank all our esteemed doctors who have joined us despite their busy schedules. In the end, I would like to thank Dr. Felix Rosenow for this insightful presentation on newer AEDs. I am also sure that all the information shared during the discussion insightful and practical. At Alkem, quality healthcare for all has been our prime focus and priority. I am delighted to inform that we have introduced two new anti-epileptics, Breveracetam and Parampanel, under the brand name of Brevasure and Parampil. Taking into the expectations of patients, both the brands are our in-house manufacturing products, and we have worked hard on quality, affordability, and availability at most leading chemists. We solicit your continued prescription support for Brevasure and Parampil. And thank you all again. And now may I request all the local teams to take the discussion ahead.
Thank you.
Thank you, sir. Thank you, sir.
Good night.
Thank you, sir. Good night, sir.
Thank you, sir. Thank you, sir.
Bye-bye.
Thank you. Bye-bye. Thanks for having me.
Thank you.
Thank you, sir.
Good night. Thank you, sir. Good night.